My name is John Myseros. Some of you know me, many of you know me, some of you don't. I'm one of the neurosurgeons at Children's. I have an office in Fairfax. I've been seeing patients there probably for about 11 years. I see most of the Northern Virginia patients and anybody from west of the Potomac, including some of the Midwest, in that office. I do care for kids at Inova, Fairfax. I don't operate there as much as I used to, just because the demands on my time force me to stay at Children's more. But nevertheless, I certainly see the patients in Fairfax and follow up with them in Fairfax, and on occasion operate at Fairfax. So I was going to talk to you guys today about essentially the big-headed kid, of which I see many, many, and I know that you guys see a lot of kids with big heads, some of whom are concerning, some are not concerning by virtue of their presentation, which is normal, but they have big heads. So I will proceed. I oftentimes, I'm not able to advance with the space key. I'm not able to advance with any, oh, here we go. Sorry. So this is a very common head growth curve for us that we see. So just as a background, I tend to use this curve. It's a Nellhouse curve. It was published a long time ago, around the time I was born, actually, in the 60s. There was a large population of kids, and I find it to be pretty predictive of the actual pathology. So oftentimes we'll see a child from the pediatricians who's had a head growth acceleration, and on the head growth curve, indeed, they've had a head growth acceleration. But when we replot those same numbers on this curve, it turns out that the head growth, albeit with a large head circumference, is actually pretty stable. I can't explain why that is, but I think this is a tried and true curve that I use both for boys and for girls. Also, I know most of you know this, but we always correct for prematurity, given that the head growth is pretty fast in the first 2 or 3 months, and if you plot these kids for their dated age rather than their corrected age, oftentimes they're crossing multiple percentiles, and if you move the curve to the left a little bit to accommodate for their prematurity, it turns out to be pretty good. But nevertheless, these two curves that I have here, the red one and the blue one, so the red one is the one that I would find concerning as a neurosurgeon, which is a persistent head growth acceleration crossing percentiles. And the blue one is the one that we tend to see a lot, which is early head growth acceleration that eventually plateaus in an otherwise normal kid. These kids are almost always developmentally on track. Oftentimes they have parents who have pretty big heads, and their fontanelles are soft. So they have an early head growth acceleration, which is concerning, but otherwise they're normal kids. And indeed, they are normal kids. It's the kids on the red curve that create a little bit of consternation. So most of the kids who have big heads but are okay have this entity, this benign macrocrania, benign enlargement of the subarachnoid spaces of infancy. There's various terms for this, but this is a benign issue. These kids on imaging, if they get imaged with a CT or an ultrasound or even an MRI, have a lot of spinal fluid around the front of their brain, sometimes a whole lot. It looks concerning. But they otherwise look fine. In my own estimation, and I think it bears out, at least in my practice over the years, I think there's a spectrum of kids who have big heads and a spectrum of kids who have big ventricles and may have big subarachnoid spaces. Most of those kids, as their fontanelle closes, will pick up their ability to absorb spinal fluid, and if you image them for whatever reason later in life, you'd see that almost all that CSF has gone away. The very small portion of kids who don't absorb their spinal fluid, despite their getting older, are the kids who have a true communicating non-absorptive hydrocephalus and may need to be treated. But those are very rare. You know, I see many, you know, maybe 100, 150 kids a year, maybe more, with big heads, and one or two of them end up having a communicating hydrocephalus, barring any other etiology, by the way. You know, they don't have a tumor or a cyst or something like that. So the kids who have big heads who actually have a problem are the ones that have true hydrocephalus, may have an arachnoid cyst, and the second half of my talk, and the thing that most pediatricians, parents, and neurosurgeons, you know, are fear that their kid might have a brain tumor. So hydrocephalus, you know, most people, even a lot of neurosurgeons, think that hydrocephalus means you have big ventricles. So a kid or even an adult gets an imaging study and the ventricles are big, and the report says hydrocephalus. Big ventricles don't necessarily mean hydrocephalus. There are children who have big ventricles for other reasons. Kids who have agenesis of the corpus callosum, for instance, they have no corpus callosum. Their ventricles are always really plump, really fat, but they don't have hydrocephalus. Those are congenitally large ventricles. If you have a kid, the classic premature baby who's born at 24 weeks gestation and does not have an intraventricular hemorrhage, but has a lot of white matter loss, they have periventricular leukomalacia. So the fluff of their brain is a little less than it ought to be, and the ventricles get big just to fill in the hole. So that's a compensatory ventriculomegaly. That's not necessarily spinal fluid that's under pressure. The difference is that kids who have hydrocephalus typically have full fontanelles, splayed sutures, and have a head growth acceleration, and kids who don't won't. This is just, I wish I had a pointer, my apologies, just a schematic of the ventricular system. The blue stuff is where all the spinal fluid is and where all the spinal fluid goes. So acquired hydrocephalus, so hydrocephalus is one of the entities that we worry about. That's one of the concerns, probably the main concern from a pediatrician who sees a kid with a head growth acceleration. Does this baby have hydrocephalus? So the causes of hydrocephalus that aren't congenital are, the classic one is a preemie with intraventricular hemorrhage. The occasional post-meningitic child, group B strep is probably the most common thing, although that is very uncommon. Post-traumatic hydrocephalus, and then, of course, acquired hydrocephalus from an obstructive brain tumor. So I don't know how well this projects for you guys, but the image on the left is essentially a normal ultrasound. Those little black wings that you see in the middle of it are the ventricles in a normal baby. On the right side is a kid who has hemorrhages, intraventricular hemorrhages from the germinal matrix due to prematurity. The white things you see in the middle are blood. And on the left, to your right, which is the left lateral ventricle, you see that big black cap. That's a pretty big ventricle on the left side. That's developing hydrocephalus. And this is a little bit later. Normal ventricles on the left, enlarging ventricles and retracting clots on the right. This is a kid who's developing hydrocephalus and will need to be treated. Congenital hydrocephalus, hydrocephalus that you're born with, is typically from aqueductal stenosis. These babies are picked up pretty early if they've had prenatal care, and oftentimes the ventricles get enormous. They just get really, really big. It's not that common, as you can see from the statistics. So there's some thought that in utero infection, most in utero infections that cause hydrocephalus are pretty indolent bugs that don't make the mom sick. Mild dysplasia or kids with spina bifida, 85% of them will end up requiring a shunt for hydrocephalus. Dandy-Walker malformations, we see a lot of Dandy-Walker variants. We see a lot of kids who have posterior fossa CSF collections, but no hydrocephalus and still have a bit of a vermis, and those kids do not need to be treated neurosurgically. We end up seeing them, and typically they're fine. Many patients have prenatal screening now, and this is picked up early, and whether families decide to proceed with surgery or not is a completely different conversation. We see those kids prenatally in our fetal medicine clinic and have long conversations, and I can tell you that in my experience, most parents do carry through with a pregnancy, but some decide not to. So this is a prenatal ultrasound. This is a baby inside her mom who has congenital hydrocephalus. Those are pretty big ventricles. This is the baby after they're born with big ventricles. The air that you see in the lateral ventricle on the left image is just air that got in there from the shunt. And the right image is the ventricular catheter and some pretty big ventricles. You can see those are big. And this is just later on, after the ventricles have decreased in size, the brain has re-expanded and the brain looks a bit happier. Communicating hydrocephalus is what I referred to earlier. Kids with big heads, head growth acceleration after they're born, who are just not absorbing their spinal fluid through their arachnoid granulations. Those kids actually can get a spinal tap and decrease their pressure. They can get a spinal tap. They can even get a lumbar drain or a lumbar shunt. I don't suggest those things. But because the spinal fluid in the brain communicates with the spinal fluid in the spine, this is a communicating system. And if they were, acutely ill for whatever reason, they could get a spinal tap rather than a hole in their head to decrease their intracranial pressure and help them, and to access spinal fluid for testing should there be a concern for infection. So this is a more of a communicating hydrocephalus picture. If I had a pointer, I'd point out not only are the ventricles big, but you can see there's a lot of CSF around the surface of the brain, because that's where it's backing up. That's where it's not getting absorbed. Throughout this talk, I have some patient examples of kids who present with big heads. So this is a boy that I saw, this is a family from Arlington, I remember quite well, who showed up in my office because of a head growth acceleration. Big kid, huge head. Developmentally, he was maybe a little bit behind, but he looked perfectly happy and healthy. He had no difficulty with upgaze. He had a big fontanelle, but a soft fontanelle. And it smelled a little fishy. He had a persistent head growth. He didn't have one of these head growth charts where he had head growth acceleration early and then plateaued. He had a head growth chart that had a persistent head growth acceleration, even on an L-house curve that I use. So I just sent him right down for an ultrasound because it was quick and easy. And at 12 months of age, it's not very easy for the ultrasonographers to image the head, even with a big fontanelle, but they did. And if you look closely to your right on this picture, you can see black, and you can see a little white line that's separating the brain from what turns out to be a pretty big arachnoid cyst. Sent him for an MRI, and this was his MRI. All that white stuff you see is spinal fluid. This is a really, really big hemispheric arachnoid cyst. And you can see his poor left hemisphere just smushed. Let me just say that when we're looking at imaging studies in this talk, whether they be CTs or ultrasounds or MRIs, the left side of your image is the right side of the brain and vice versa. So this is a left arachnoid cyst. The brain is pushed from the left to the right, and you can see the ventricles. Both ventricles are on the right side of the kid's brain. So he ended up getting a shunt for his cyst and has done quite well. So arachnoid cysts are not that common, but they can cause both hydrocephalus and they can cause a really big head, either from the hydrocephalus because of the obstruction from the cyst or because the cyst is so large, like this little boy. Incidentally, his development, that was quite a few years ago. He's probably 8 or 9 years old now. He is a precocious, highly intelligent, very sort of accomplished little boy. He plays the violin. He's a superb student. He's a good athlete. You'd never know it looking at the MRI that he had at 12 months of age. We treat arachnoid, this isn't a discussion about how to treat arachnoid cysts, but we can shunt them or fenestrate them depending on their location and the age of the child. So here's another little kid, 10 months of age, who shows up with a big head and head growth acceleration. This fontanelle is a little bit full, but the kid's cruising around, happy, by every measure developmentally normal. Ends up with an ultrasound as well because the fontanelle is pretty big and because they can just run downstairs and get an ultrasound without having it scheduled and without any sedation. And he has, you can see his ventricles are big, and right in the middle there's a big black thing. So that's either a big third ventricle or an arachnoid cyst. So he went for an MRI, and indeed what he has is a big arachnoid cyst. Again, I don't have a pointer, but all the white stuff you see is spinal fluid. And essentially you can't see the pituitary gland, and the whole middle of the picture is a big cyst that's compressing. It's pushing the basilar artery back, it's pushing the brainstem back, it's pushing the third ventricle up. So this child had a suprasellar arachnoid cyst, which we actually fenestrated. The cyst decompressed, it decompressed the cerebral aqueduct and took care of the hydrocephalus. This is a 6-week-old boy, so this is a little bit different. This is a 6-week-old. This is essentially an infant. Failure to thrive, ends up in the emergency room, forced downward gaze, tense fontanelle, without any imaging. You know, if it was 50 years ago, 60 years ago, no imaging, the diagnosis on presentation would be hydrocephalus, probably congenital hydrocephalus. Big head, full fontanelle, forced downward gaze. So he goes for imaging studies. He had a CT scan and went straight to an MRI. And I don't know how much you can appreciate. Without a pointer, I can't show you very well. But essentially, what you see here, spinal fluid is black. You don't see a bunch of black. What you see is a bunch of different colored lumps in the kid's brain, which essentially is a big brain tumor. Here's an axial image. So the front of the head is in the front, the back is in the back, and the white stuff you see is spinal fluid. So there is some hydrocephalus, but that big thing that you see predominantly on the right side that goes on the left is a big teratoma. It's a huge congenital brain tumor. It turned out that we biopsied this, and it was an immature malignant teratoma. He was treated with chemotherapy, sort of salvage therapy, frankly, because teratomas don't behave. They don't respond very well to chemotherapy. It didn't change very much. He lived about 3 or 4 more months. We biopsied it again, and it was a mature teratoma, which turns out to be a more benign tumor. We took it out, and he's been tumor-free. That was probably 7 or 8 years ago. So he is neurologically devastated, I should add. But, you know, his mom is very thankful for having him. He's a sweet little boy. But he presented with what we thought would be hydrocephalus, but turned out to be a brain tumor. This is another infant who was born out in Stafford, I recall. Looked okay at birth, but had rapid head growth acceleration afterwards. I don't believe saw their pediatrician and ended up in the emergency room just because the kid's head was so big, and was imaged with a CT scan. I won't show you the CT scan because I have an MRI, but this is the scalp film for the CT scan. I don't know if you can see it and appreciate how large this baby's head is. It's really big. And this is the MRI, a coronal image, so we're looking straight at the child. And those are about as big of ventricles as you're ever going to see. You can see the brain is so thin. And right in the middle, there's a white thing, and that white thing is a choroid plexus papilloma, a very rare tumor in a child, but in a position where it not only blocks the spinal fluid from getting out, but because it's made of choroid plexus, and choroid plexus essentially makes most of the spinal fluid, these tumors just churn out spinal fluid. They make a lot of spinal fluid. I should say about that baby, so operating on a baby to take this out in the middle of his brain is pretty treacherous. So the first thing we did was took care of the hydrocephalus, so we shunted the baby. He made so much spinal fluid that he got ascites. So we ended up externalizing him. So at 2 months of age, with an external shunt, he was putting out a liter of spinal fluid a day. You know, a normal baby would make 200, maybe 250, 300 cc's of spinal fluid a day. He was putting out 1,000. And what we actually did was we had this tumor embolized. It killed the tumor and resolved all of the mass effect. He still has a shunt, but his hydrocephalus is slowly resolved, and he's actually done quite well without any surgery for this tumor. So it was a case report. We actually published it. So this brings up the second part of the talk, and the issue that most people are mortified about which would be a brain tumor in kids. It turns out that brain tumors in children, at least as solid tumors go, are pretty common. In the general population, they're not that common. We have a very big brain tumor center. We have one of the biggest pediatric brain tumor institutes in the world, and a pretty large referral. So we see a lot of the kids. Roger Packer, who's the head of our brain tumor program, he's a neurologist and the head of our neurology and neuroscience program. He gets referred quite a few patients from the outside, and we, particularly Bob Keating and I, get a fair amount of referrals from outside the institution. We see a lot of kids with a lot of pathology that isn't cared for elsewhere. So we see an inordinate amount of brain tumors, but I'm sure a lot of you that I'm speaking to have seen, had a kid or two or maybe more in your practice that has had a brain tumor, but there are some pediatricians that will go through their whole career without seeing any. We live in a fairly large cosmopolitan area, so the volume is fairly high. Second most common brain tumor, most common solid tumor, most common solid tumor, second most common neoplasm. Most common neoplasms obviously are leukemias and lymphomas. We see a fair amount of malignant tumors because of our referral, but not to be dismissive of any child with a tumor or a parent that has to take care of our pediatrician, but some of the tumors we see are benign, and the children actually do quite well. So here's another example. This little girl who presented with a tremor. She had been percolating along for a really long time. Interestingly enough, did not have a headache, did not have vomiting. She just wasn't keeping up with the other kids at school. Intellectually, she appeared to be okay. She got an MRI, and she has this very large posterior fossa tumor. So as you're looking at this child, you can see her nose to your left and her forehead and her brain. She has hydrocephalus. All that black stuff is water. That all those white lines and dots in the back of her head are the tumor. Her brainstem is completely compressed. You can't appreciate it, but she actually has a Chiari malformation, and imaging of her spine showed a huge syrinx, just like any other kid with a Chiari. But she had a Chiari because the tumor was smushing her brain, right? It's pushing her brain down. This is an axial image. You see her eyes in the front and her nose in the front, and you can see this big tumor in the back. She went to surgery, and we took it out, and she actually did quite well. She did not require a shunt. She had a low-grade astrocytoma. These are the most common diagnoses we see. So the most common astrocytoma in an adult is a glioblastoma, which is bad news by any measure. That's one of the most malignant brain tumors there are. And glioblastomas in children are just as bad. It's essentially a fatal disease. There are some long-term survivors, but it's bad. Medulloblastomas are the most common posterior fossa tumors we see. It's between them and cerebellar astrocytomas, like the one I just showed you. Medulloblastomas are malignancies. However, we've learned a lot about the biology of these tumors. It turns out there's at least 4 different subtypes of medulloblastomas, and some do very well. Some are cured. 85% of medulloblastomas have a 5-year survival rate, or alive at 5 years, I should say. So 55, 60 years ago, before the advent of radiation, the mortality for medulloblastoma was 100%. So we've done very well with treating these tumors. Craniopharyngiomas are benign lesions. I'll show you some pictures. They're just very difficult to take care of. We do see germ cell tumors. Ependymoma is a little less common, and many, many, many other kinds. There's hundreds of different brain tumors, but these are the most common ones. So we tend to think about brain tumors by location. So here's a sagittal MR of a normal kid. That yellow line is the tentorium. That's sort of the shelf that differentiates between the top of the head and the bottom of the head. So everything above the line is supratentorial, which essentially is your frontal, temporal, parietal, and occipital lobes. Everything below that line is infratentorial, which is the cerebellum and the brainstem. This area that I've circled is where the pituitary gland is in the optic chiasm. That's essentially the sella, and the area above the sella, which is the suprasellar region. That's where that arachnoid cyst is that I showed you. That's where craniopharyngiomas grow. That's where pituitary tumors grow. And this is the 4th area, the pineal region, which is the back of the 3rd ventricle. Very difficult spot to operate in, but we do see tumors there, and they typically present with, I'll talk to you about that, but they typically present with hydrocephalus because they obstruct CSF flow. So supratentorial tumors can get really big. They can get enormous before they show problems. But the classic presentation is visual acuity issues. They may have speech problems if it's affecting their speech cortex. If it's big enough, it can make them weak based on location. Gerstmann syndrome is a dominant parietal lobe syndrome where kids who have, it's very rare that you see it, but they have right-left dissociation. They can't tell you right from left. They can't recognize their fingers, and they have difficulty counting. They otherwise seem quite fine. Obstructive hydrocephalus, of course, is a very common presentation, particularly in children. We do see kids with new onset seizures who have tumors, but it's not nearly as common as adults. A new onset seizure in an adult is a brain tumor until proven otherwise. In a kid, it's much, much less frequent. Posterior fossa is a very small area, so the tumor there doesn't need to get very big to start causing problems, particularly hydrocephalus and vomiting. You hear about morning vomiting and get concerned when you hear that story. Kids vomit in the morning from posterior fossa tumors typically because when they're lying down and they're sleeping, you know, when we sleep, we hypoventilate, so we retain carbon dioxide, which makes us vasodilate a bit. So if they already have a lot of volume in their head, particularly in their posterior fossa, a little bit extra blood makes the volume a little higher. By the morning time, they've retained enough carbon dioxide that they've maximally vasodilated, and it pushes them over the edge. They're lying down, so their venous outflow from their head isn't great, so that increases the volume. So by the morning, they're sick, they puke, they get up, they breathe more normally, their CO2 returns to normal. They're standing up, so the venous outflow from their brain increases, so the volume in their brain decreases, and they feel fine. So they can go on for weeks and months with this vomiting in the morning, feeling perfectly fine thereafter. And that's why some of these kids go undiagnosed for a long period of time. You know, who'd think that they have a brain tumor, but sometimes they do. Cranial neuropathies are not as common. We do see it in kids with pontine gliomas, which is a terrible disease we can talk about. And nystagmus is a little rare, but we do see it particularly with cerebellar hemispheric tumors. Pineal region tumors present with obstruction and a Paranode syndrome. These kids can't look up generally. Sometimes they'll actually look down, and they'll have retraction nystagmus. If you have them follow your finger in, where most kids would cross their eyes as you get close to their nose, these kids will have nystagmus as they cross their eyes. And suprasellar tumors almost always present with visual acuity and pituitary issues, particularly craniopharyngiomas. If they're big enough and they affect the hypothalamus, these kids will have a diencephalic syndrome. I had a kid, every time I read this diencephalic syndrome, I had a child who presented to the hospital with, she was 4 years old, she wasn't eating, she had lost weight, and she was diagnosed with depression. She was actually on psychiatry service with a nasogastric tube. And she eventually got an MRI, and she had a huge craniopharyngioma. It would be very rare that a little girl that age presents with depression and not something actually organic. Not that depression is not organic, but pathologic in her brain. So I'm a surgeon, that's what I do. And we don't always operate, but oftentimes we do, particularly for tumors. Typically, the child will show up with symptoms. If they have no symptoms and the tumor's found incidentally, we may actually not operate, at least not initially, but usually, I mean, the goal of surgery to make the kid feel better, obviously, hopefully to resolve their symptoms, to take care of their hydrocephalus, take care of the increased intracranial pressure, certainly make a diagnosis so we know what we're dealing with. If the tumor can be removed, I mean, there's not a tumor in the world that is going to be more easily treated big than small, right? So if you can remove it safely and it's a benign tumor, it may be cured. If you can remove it safely and it's a malignant tumor, you still have a better shot at curing it. And if you can't remove it completely safely, the more of it you can remove, the better they're going to do in the long run, for the most part. That probably doesn't hold true for for glioblastomas. And for a tumor called an atypical teratoid rhabdoid tumor, those are bad news. But with the exception of those, certainly the more you get out, the better. Ultimately, though, we don't want to hurt the child, and that really needs to be taken into account, particularly with the location of some of these tumors we take care of. So just some examples of some tumors. This is a little kid. You can see the scalp film for the CT scan. You can see this, if you look closely, we're looking, it's sort of like a lateral x-ray, right? So this baby's chin is on her chest. You can see she has a teeny little mouth. You see the endotracheal tube? That denotes the mouth, and her teeny little nose, and her head is just huge. So she was born like this. This was not picked up on prenatal ultrasound. I don't recall whether she had one earlier, but it was not. They did an ultrasound at the time of the delivery, and the baby was born by cesarean section. And I got a call from the resident. I got these images sent from an outside hospital. What should I do? You can see the CT scan. The entire intracranial volume is tumor, all of it. This baby's eyeball was hanging out because the tumor had pushed through the back of the orbit and pushed the eyeball out. So I asked the resident, I said, well, you know, what do you think we should do? She said, operate? I said, no, not operate. This is, you know, this is a 36-week baby who has essentially a congenital malignancy. These babies always have malignant brain tumors, typically sarcomas of some sort. She said, let the mom have the baby for a little while? I said, yeah, let the mom have the baby for a little while and let the baby go, because we can't do anything for this baby. We can't operate on her. We can't treat her with chemotherapy. So it's very rare that we see this, but this is one of the bad things we see. Pituitary tumors are nowhere near as common in children as they are in adults, although craniopharyngiomas are more frequent. This is a kid with pituitary tumor who presented with acromegaly and growth hormone. You can't tell from the MRI. Usually these kids have acromegaly and a big sort of bulging forehead. This boy didn't. We went transsphenoidal through the nose and took out the tumor. The image on the right is post-op. This is a craniopharyngioma. So this is a big tumor sitting right in the middle of the brain. Here's the axial image after the resection. Here's a sagittal image, and this is how we remove these tumors underneath the frontal lobes with the head tilted back, and gently lift up the frontal lobes and take out the tumor. You can see how far back the tumor goes. You know, from the surface of the skull to the back of the tumor is about 10 centimeters. It's about as far as our instruments will fit. But, you know, with a little bit of finesse and a lot of care, you can remove these tumors fairly safely. These children are if any of you have any children who've had craniopharyngioma surgery, I mentioned earlier the benign tumors. It's not a benign surgery or post-op course. These children uniformly have panhypopituitarism. They have diabetes insipidus. If they don't have it before surgery, they certainly will. They need to take growth hormone. They have oftentimes morbid obesity because they have no hypothalamic receptors to tell them that they're full, so they're always hungry. Many of them become morbidly obese. They have to take cortisol. They have to take BD-ADP for their diabetes insipidus, and they have to take thyroid. So, I mean, that's a real issue in these children's lives. And there are some people who think that these children should receive radiation. It's very difficult to radiate a tumor this big when it's solid and think that you're going to cure it, because you're not. Some of the cystic tumors you might. Here's an ependymoma. We see these both in the brain and in the posterior fossa. You can see all the edema around this tumor on the image on the left. The image on the right is after it's resected. This was an anaplastic ependymoma, which unfortunately recurred even after resection, chemo, and radiation. The child ended up losing their life due to this tumor. This is the same image in a coronal. You know, the surgery looks good. There's nothing there. The child did very well, but it recurred. Really no other options. We removed it one more time. She did fine, but we said we can't just keep operating. They re-radiated her. The radiation oncologists are very, very careful about re-irradiating a child because radiation can be quite detrimental, particularly the growing brain. But she went to heaven. This is a classic medulloblastoma, a tumor in the fourth ventricle between the cerebellum and the brainstem. We approach it suboccipitally and remove them. A lot of these kids do pretty well. This is a kid, I added this kid, I operated on this girl on Tuesday, 3 days ago. She's from one of our colleagues' practices out in Stafford. She presents with this pineal, so this tumor is in the pineal region. At the end of the yellow line is where the tumor is. So it's in the posterior third ventricle, underneath the internal cerebral veins, above the cerebellum, causing hydrocephalus. And her image on the right is after surgery, after we removed the tumor. It turned out to be a pilocytic astrocytoma of the tectum. You'll see that she really has no tectum of her membrane left. So she's actually done quite well, except her eye movement. She can't see, she can't look up, and she has bilateral ptosis. I'm hoping and praying that that improves. It's very difficult to take out these tumors, and many people don't even attempt to do this. The problem is with a benign tumor, they don't respond very well to chemotherapy or radiation. Removing the tumor typically takes care of their hydrocephalus. They get away without a shunt. They're usually cured. They have to deal with some of these eye movement problems. but oftentimes because of midbrain surgery, they won't wake up. You know, they remain in a constant vegetative state. Fortunately, she's actually going to go home today, but she needs some help from her parents getting around because she has to tilt her head back to see. She can't completely open her eyes. Again, over time, hopefully that improves. Here's a kid who presented with what looked like a benign tumor. Again, without my pointer, it's hard for me to show you, but this is the brain, obviously. There's the skull, the edges of the skull. You see there's a craniotomy. The dura is sort of the grayish stuff where there's some sutures pulling it back, and then there's the brain. Within the brain, towards your left, there's a lump underneath the brain. You can't see it in 2 dimensions, but essentially there's a tumor. Immediately to your right, you can see all the veins in the subarachnoid space, but you see some pink stuff. It looks like almost like somebody, it looks fuzzy. That's all subarachnoid tumor. That's metastatic diffuse tumor in a benign brain tumor. You can't cure this kid with an operation. As a matter of fact, it's very hard to cure this kid anyway with a benign tumor that's metastatic. She actually still is doing pretty well, but even benign tumors may be metastatic. So as a neurosurgeon, if any of you guys know any of them, you know, most neurosurgeons are pretty proud of themselves about removing tumors and show all these wonderful post-op films like trophy cases. You know, not to be cliche, but we're treating children, not pictures. We can make pictures look really good and make kids look really bad. So quality of life is a really big issue. This is a kid who had a craniopharyngioma. I could have probably asked you what kind of tumor did this kid have, and based on what I was talking about earlier, you probably could have guessed. So you can see this little boy is just big. He's only 7 years old. He ended up getting growth hormone and got tall and much thinner, but still, quality of life is a big issue. He took a bit of a cognitive hit from his tumor. When he presented to us, he was already two grades back. I mean, he presented to us when he was about 7 or 8. You know, he was redoing kindergarten. There's not a lot of kids who have to repeat kindergarten because there's very little intellectual sort of requirements. But anyway, he's done pretty well. But again, he is not perfect. Here's some of the sequelae of our treatment. So this is a kid who had posterior fossa tumor and got radiation and showed up a couple years later with this thing on the left, all that white stuff. It turns out this is not a radiation-induced tumor, but it's dead, you know, dead tissue, dead brain from radiation. The brain gets injured. If it's not in the brain stem and it doesn't kill them, they typically this gets better. But it's a lot of damage to what would otherwise have been normal brain within the range of the radiation. This is a kid who did have a radiation-induced tumor. He had a frontal lobe tumor that got radiated, and now he has a parietal lobe. It's a meningioma. It's a benign tumor, but probably radiation-induced. It was removed, and he's done pretty well. So how can we do better? How can we avoid some of the problems that we have? Well, there's avoiding some of it, but a lot of it is unavoidable. Either you're going to do the surgery or you're not. You have experience or you don't. You have judgment or maybe not such good judgment. So every kid is unique, and we should approach them that way. Not every child with a frontal lobe tumor is going to do exactly the same. Not every kid with a malignancy is going to do the same. We do use things in the operating room to help us. We have here at Children's, we have an intraoperative MRI. We have an intraoperative CT scan. We have real-time ultrasound. We can use functional MRI. I'll show you some pictures and tractography to try to avoid problems. There's chemotherapy and radiation, biologic therapies now. There's convection-enhanced delivery where you can put, there's a new protocol starting that we'll be part of where you can actually put a little wire in the brain, particularly brainstem tumors, and infuse directly into the tumor, slowly infuse chemotherapeutic agents. There's a lot of things coming down the road. I think, you know, science is so advanced, probably one day we won't need to operate on tumors. Probably 50, 60 years from now, 100 years from now, they'll look back and think we were barbaric in what we were doing. But for the moment, surgery is important, and I should say that our patients uniformly do very well. Of course, we'd rather not have a job with regards to this. We'd rather not have to do any brain tumor surgery. Here's a functional MRI. This is a child. If you look to the image on the right, image C, all the little arrows are pointing to a tiny little tumor. This is, when you first see this, you say, boy, that is really close to the motor cortex. We're going to take this out, and we are going to paralyze this kid, or at least make him weak. In the middle, on the image in the middle, the arrows are pointing to his motor cortex. So if the child is old enough, they can sit in an MRI scanner, and there's neuropsychologists who do testing with them and speak to them and have them read and have them talk and count fingers and move their toes and see exactly where their speech is, where their motor cortex is, without having to put, grids and wires in their brain to find out. It's a very eloquent way of doing it. Those arrows are pointing to the kid's motor cortex, and immediately behind all the blue stuff is a dark area. It doesn't project very well. That's the tumor. That's the tumor that you see further on the right that's enhanced. So we know that this kid's motor cortex is right in front of the tumor. So if you approach it from behind, you're more likely, you may get a sensory deficit, but you're more likely not to hurt the motor cortex. And that works really, really well for avoiding neurologic problems from tumors in eloquent areas. This is a coronal image. All the yellow, all the orange stuff that you see at the top of the brain is the motor cortex, and all the little fibers you see coming through are the motor fibers. The tumor is that sort of pale white stuff right to the left of you on the bottom part of the MRI, and you can see that the majority of the motor fibers in this kid, here's another view, the kid's head is tilted. You see the brain tumor, but you see the majority of the orange fibers are medial to the tumor. So we know that if we stay away from the medial portion of the tumor, that it's likely we can, even though it's in the thalamus and people don't operate on the thalamus, we can go in there with the right trajectory and avoid making the child weak or paretic or plegic. It's pretty amazing and precise technology. So I've been doing a lot of talking, but a lot of people want to know very sort of rational, logical, practical things. When do I pull the trigger and get an MRI or a CAT scan on a kid? In our I'll speak for our emergency room and probably most emergency rooms. Like my chairman used to say, sometimes you have to make the ultimate sacrifice and actually examine the kid. We are very quick to image kids for fear of missing something. It's so easy to get a CT scan, and nowadays even easy to get an MRI, that there's a problem, there's an issue, there's a concern, you just image the kid just to make sure there's not a problem. And I can't say that I blame anybody for doing that, but just to put some things in perspective. New onset seizures in kids, like I said earlier, very rarely is it from a brain tumor. In an older kid and a teenage kid, maybe, but in a young kid, almost never. Isolated headaches are typically not from brain tumors. So imaging those kids right off the bat is not necessary. Worsening headaches are of concern. Repetitive, classic migrainous symptoms with auras and vomiting and light sensitivity with a strong family history are probably truly migraine headaches. Even in a young child, it does happen. But morning headaches and progressive headaches and worsening headaches would be a concern, and I would image that child. New onset or a progressive neurologic deficit. So any kid with an acute neurologic problem should be imaged. It may turn out to be a migraine. I've seen children with migrainous seizures. I've seen kids who have, belly pain who turn out to have a brain tumor. But those things are quite rare. So a new onset neurologic deficit may be a migraine, but if it's severe enough to concern you and the family, image them. MRI or CT, honestly, we can have a long conversation about the virtues of doing an MRI because CT scans offer radiation, but in most institutions, a CT scan can be done quickly, pretty low radiation without sedating the kid, and anything obvious and bad will show up. You're not going to miss it on a CT scan. You may miss something subtle, but if it's subtle, it's not an emergency, typically, unless there's been a subtle subarachnoid hemorrhage, which children seldom have. And in the very young, a full fontanelle, sun-setting eyes, splayed sutures, those kids need to be imaged. So I spoke sort of quickly, and forgive me for that, and I didn't have a pointer to make my point on some things. Forgive me for that as well. But I hope that this was useful, and I'm very happy to take any of your calls. Thanks.
Thank you so much. Did anyone have any questions?
Did everybody hear me and see it? Okay, I hope so.
Great. Well, thank you so much. And this will be posted online if anyone wants to view it again. And thank you for your time.
Okay. Thank you, everybody.
Thank you.
Bye-bye.
Bye.